Well, good afternoon again, everybody. Welcome to our Introduction to Telehealth ECHO series that we're holding in partnership with Renown Health. Glad to have you joining us here today. We'll go around, we'll start off with introductions as is standard practice here at Project ECHO. We'll hear from our hub team and subject matter experts here today, then on to all of you joining us out there. So I am Troy Jorgensen. I'm the program manager for Project ECHO Nevada, and welcome today. Michael, if you want to go first.
Hi, my name is Mike Howitt. I'm a supervisor of telehealth here at Renown Health. Been with Renown for about 7 years, but I've been in IT for about 17 years. I originally started my IT career working as a student tech for the community college, so TMCC. But I've always had an interest in IT, and I've always been fascinated with technology. I'm also very passionate about education and healthcare. So to me, I'm super excited to be here with you guys today.
Thanks, Mike. Mitchell?
Hi, I'm Mitchell Fong. I'm Director of Telehealth at Renown Health. Really excited to be here as well. Thank you for those that are joining us. I see some new faces, some familiar faces. Just really appreciate you guys coming in. Hopefully today we can continue the lessons and continue adding value to our community. So thank you all for joining today.
Thanks, Mitchell. Crystal?
Good afternoon. I'm Crystal Larson. I'm a telehealth coordinator here at Renown. I've been in my current role for about 3.5 years, but with Renown for almost 5. And I'm also excited to participate and help provide some information on the telehealth program.
Thanks, Crystal. Jessica?
Hi, everyone. My name is Jessica Thompson. I am the manager of the telehealth program here at Renown. I've been in this position for just over a year now. I've been with Renown for 5. My background is primarily in rural nursing. I am an RN, born and raised in Tonopah, Nevada, and worked at our rural facility here for 25 plus years until we had to close it down. And I'm thankful to be here with you today. Thank you.
Thanks, Jessica. Gary?
Good morning. Sorry. My name is Gary Beck. I'm the Director of Rural Health Services here at Renown Health, and been in this position for a little more than 3 years. And prior to that, I was with Renown's Institute for Heart and Vascular Health in a position as Director of Business Development. And then prior to that, I was with the private practice cardiology group in Reno with an extensive rural outreach program. So I've been fortunate enough to be serving Northern Nevada and Eastern California rural communities and rural hospitals for many years. And I have always enjoyed the opportunity to work with our rural hospital partners in rural communities and trying to meet their needs, healthcare needs in particular. And just appreciate the fact to be able to join you today and be a part of this great telehealth team. Thank you.
Thanks, Gary. Good to have you. Sneha?
Hi, everybody. My name is Sneha Sharma, and I'm the program coordinator for Project ECHO Nevada.
All righty, that's our team here for you today. And now on to you joining us out there. Deborah?
Hi, my name is Deb Arno. I am a psychiatric nurse practitioner. I am currently working in the med school's behavioral health clinic, and I'm doing only telehealth right now, and only to Ely, Nevada, with the state rural system under a contract with the state, with UNR. Thanks. Glad to be here. And I've been doing it for about 7 years, so thanks.
Great. Good to have you today, Deb. Thank you. Catherine?
Hello, I'm Catherine Wade. I work as a psychiatric mental health nurse practitioner, licensed alcohol and drug counselor, currently working with Dr. Philip Molinas.
Thanks, Catherine. Good to see you today. Terry?
Hi, my name is Terry Lightfoot. I'm the Director of Physician Outreach for Renown Health. I've been with Renown either as an employee or a contractor for a little over 8 years now.
Thanks, Terry. Welcome today. Good to have you. Oh, sorry, Terry. I muted you there.
I was just saying I'm very excited to be here. I think this is a fabulous project for our state, our community, and our state, and here to give you all of my support.
Appreciate that. Thanks, Terry. Welcome. Katie? Oh, Katie, you were off mute there for just a second. Katie, if you could unmute and introduce yourself for us, please. I clicked ask to unmute from my end, which I think gives you an alert to unmute yourself. Then we should be able to hear you. Looks like troubleshooting some issues there. All right, Katie. Amber?
Hi, I'm Amber Batchelor from the Nevada Coalition to End Domestic and Sexual Violence. I've been working in the field of domestic violence and sexual assault since right out of grad school 100 years ago, it feels like. And I'm here because I need to learn more about telehealth and how we can apply that to increasing, actually in some areas, providing sexual assault services for sexual assault survivors, particularly in the rural areas. So I am very happy to be here. Thank you.
Thanks, Amber. Welcome today. Dr. Bien?
I'm Dr.
Oh.
Sorry. I'm David Bien. I do some primary care and hospital medicine in Ely, Nevada. I'm an internist.
Thanks, Dr. Bien. Always good to have you. Katie Day?
Hi there. My name is Katie Day, and I work with Nevada Medicaid, and I'm a policy specialist. And one of the policies I oversee is for telehealth.
Thanks, Katie. Welcome back today.
Thanks.
Neil?
Hi, everyone. My name is Neil, and I work for a company called Genentech. We're a biotech company, and one of the things that our organization is striving to do is help other healthcare organizations achieve the triple aim. And one of the things that I'm trying to learn is how organizations are using telehealth and telemedicine to help achieve some of those goals. So I'm very happy to be here, and I appreciate you guys including me.
Thanks, Neil. Great to have you today. All right. Well, thank you all for introducing yourselves. Again, welcome today. Thanks for being here. All right. I'll turn it over to Mike and Mitchell for our didactic. Always during the didactics, feel free to unmute yourselves or write them through the chat box. If you have questions, comments, thoughts, concerns, anything like that, feel free to chime in. All right. Go ahead, Mike and Mitchell.
Yeah, and I'll just echo what Troy said. We really want to make sure this is valuable for you. So please ask your questions, interject, post them as we go through. We really want to make sure that we're meeting the need as we move forward together. This is really part 2 of a 4-part series. So as we move to the next slide, you'll see that today it's about getting started, technology and partnerships. Well, we really wanted to break this getting started because it's so in depth into multiple sessions. So the next session will be more about the training and the onboarding. But today we're going to really focus on how do we select platforms, how do we communicate and work with our partners to ensure we're building that sustainable infrastructure to set us up for success and scalability long term. Last time we talked about what is telehealth, what are the different modalities, and what's really the value propositions in urban and rural telemedicine. And so we kind of want to just take us through the steps of starting to get that vision to today. We'll talk about building that vision and strategy, and then working forwards to select a partner and a technology vendor that will help you achieve that mission. So again, we want to move forward with our disclaimers and just say everything that we share today is the view and mindset of ourselves, although we will be using examples from Renown Health as that's where we work. A lot of the opinions and perspectives we provide are our own. The next slide is an introduction slide, but we've already went through that, so you know who I am, and you've heard now who Mike is and his passion for healthcare IT. I think it's always extremely exciting to find those from different backgrounds that can come together with a common purpose. That's one thing I think Mike does very well is, being someone who's so familiar with technology his entire life, I can really see the passion that came forward when he moved over to the telemedicine team and started working with us, because he truly believes and understands that his work now impacts patient lives. And I think you guys will hear that as we move forward and you get to hear from him a little bit more. But just to outline the agenda for you today, we'll start with, we already did introductions. But we'll start with strategy. And then from there, finding the right fit, determine the scope of services and the scope of relationship. So you can really figure out how to choose your strategic partners. And I am saying partners specifically, not vendors, which we will get to then further go through what are the technology considerations we have. And we want to make sure we save some time for questions and answers and open discussion. But again, I will state this, and I can't stress it more. Please ask questions intermittently as we go through, because we want to make sure that we're giving you the most value possible as we go through this session. If there's anything that you want to hear related to that, just type it in and we'll see if we can get to those topics as well, or see if we can add them into a future session. But let's get started with the why. I'm always think when you're building a strategy, you need to start with the W's. That's the who, what, when, where, why. And for me, it's the biggest value proposition is really determining the why. Why are we doing this? What's the impact we're expecting to have? And who are we trying to serve? I know this really sounds a little redundant from the prior session, but again, it's about what services do we need? Particularly when we think of rural communities, we think of that access to specialty care. When we think of those urban populations, it might just be convenience care. I'm always at work, I'm stuck in traffic. I'm always at my kids' ball games or at my kids' school. I'm teaching them from home now, so I can't get in when the doctor's office is open. So that's things that you need to think about as you're building your program is, what is the value proposition that I'm trying to create? And maybe it's multiple. Maybe you want to do all of these things, and that's fine. That's fine. And that's actually amazing if you can achieve that. But really take into consideration some of the things we talked about last time, the rurality versus the urban. Is there a state line that you crossed? You need dual licensure, multiple state licensure. From a treatment model, there's differences between consultative and treatment, where in a treatment model, the providers that are delivering the telemedicine services are actually able to treat and order prescribed for the patients, versus a consultative model, where those providers are consulting with the patient and another provider in the room, so that the patient's PCP or referring physician still has the ultimate say as to what needs to be ordered and prescribed for this patient. We also want to consider what's your structure for reimbursement? Are you in a hybrid structure? Are you a value-based care, capitated model organization? Are you fee-for-service? Are you insurance arm? And really, so understanding that piece of it will help you build what you're trying to do to make sure you're getting the patients in the community the right care. And again, is it direct to consumer? Is it provider to provider, clinic to clinic? Is it acute to acute for a telestroke program? And so there's some of those things that you really need to consider as you're creating the vision and creating the strategy. And then we move forward to, okay, now we've kind of defined what those goals are. We've refined what that strategy is. Now we really need to get to the details. And I always say, build with the end in mind. I'm a big fan of design thinking. So this little animation here of the goal at the end and building a bridge, that's really what I think are the steps to then taking a vision and creating an actionable strategy, where you're now getting into the granular details of, okay, who is our population? And it might be a split of rural and urban. How do we get to them? Are they located in prisons? Are they at tribal health centers, critical access hospitals, rural clinics? And so we want to make sure that we're building it with the flexibility to meet all of those that you may encounter, whether it's now or in the future. Again, going back to that payer mix, because you want to make sure you're building something that's sustainable, scalable, and really align with what your big vision is, whether it's an enterprise goal or the goals that you're setting for this specifically. And then technology capacity. What can you support on premises? What type of support do you have in-house? What do you need to outsource? Those are the type of things to think about. And further, when we think about those rural populations, it's what's the connectivity? Do they have broadband? Do they have cellular? Is it 5G? Is it 4G? What can they do from home? What can they do from clinics? That's going to be very unique for every different community that you work with. So understanding that is very important. And then again, going back to those service lines, do we want synchronous, real-time, interactive video and audio? Do we want asynchronous? Do we want both? Asynchronous for a lot of communities is better because you can store and forward that. And it doesn't matter if you have spotty service, because while it may not send immediately, whenever you get service, that can get sent. And then your provider can then see that image and still review it. And from a patient perspective, obviously it's better to get the right care at the right time. But if I can be in Winnemucca and still send that over to a provider hours away, wouldn't it be better to still get that to the provider within 15 minutes when I have good service versus driving all the way in 2 hours to get this care? specifically if it's a wound, if it's a minor cut, something like that, if it's a pink eye picture that you want to do, and maybe we can then help triage that and determine what's the right level of care for that patient. Do we want to deploy a mobile team out there? Do we want to set them up with a virtual visit? Do we need them to come in-house? So that's some of the reasons why you may want to have asynchronous in addition to the synchronous video sessions that we have like today. Again, the care settings, if it's a telestroke, where are you building it? Is it ED only? Is it on your inpatient floors? Is it at partner facilities as well? And again, getting back to that reimbursement model that we talked about, it's really defining that. And as you go in and refine your strategy, you're not just going to be looking at, do we do one or the other? You probably want to think about, what's my roadmap in 1 to 5 years? Let's say if you're a health system and you're a provider, are we moving towards a direction of being a part of an ACO? Are we trying to expand our ACO? In that case, we're going to see a shift towards value. Are we staying in a fee-for-service market? And that's kind of what we're doing today and what we anticipate to continue moving forward just based on the populations we serve. And so that'll help you think about what's the type of model that we want and what are those value propositions that we're trying to get to. But I always say, know that the end is a moving target, particularly in telehealth. Everything evolves. Whatever you built yesterday is out of date as of today. Sometimes that means it's still good, but it's not the best. And you want to continually refine what you build. So don't always build it and think you need to stop improving it, but build it with those metrics in mind to continue to improve the process. But again, knowing that it's a moving target will allow you to be flexible and dynamic in where you need to go, but it'll also enforce you to think about being agile. And I think that's the key when we think about bringing technology into the health space, is making sure that you're agile to meet the patient where they are and creating much more access points for patients to get that care. And as we move forward, just what we've learned a lot is get your key stakeholders involved from the beginning. We learned this, and I'll say we struggled with this at times, and we learned from our own mistakes. We worked well with some of these partners, and these are just an example of a list of different partners you may want to bring to the table up front so you can build a collaborative strategy that'll work for all. We worked closely with our physicians and our customer engagement center and our IT team, but historically we learned that we didn't do a great job working with our billing department or our finance department to make sure we were doing things in an optimal way, forcing the documentation in an optimal way. And so we've improved our processes over the years, but that's something that, giving guidance to others, I would say, look at that up front, bring those key stakeholders in, bring in your population health management team, your coordination, your command center, your marketing. I think marketing is something that's extremely undervalued, but how do you expect patients and providers to use the tools if they're not proactively engaged with understanding the value and the access that they have? Bring in your payers, particularly if you want to move to a value-based structure. Bring them in, show them what you're doing, see how you can build that and what programs would be meaningful for them. A part of that is helping you define what are your KPIs, your key performance indicators, are the metrics that you need to track to be successful. And if you're trying to move to a value-based organization, you're trying to secure some of those contracts, it might be that we want to look at what's your reduction in ED visits, what's your improvement in quality scores, how is your access changing? And so those are some of the things that you really want to think about as you're building your relationships. And again, build with the end in mind, thinking about sustainability and scalability. And so if there's federal funding programs, if there's grant opportunities, look for partnerships to pursue those so that you can have the resources to really expand and grow and make sure you're meeting the need for that community. This next slide, we just wanted to give a sample of, it's a very, very simple, straightforward org chart, but based on your site and what you have, you may have a completely different organization chart. We just wanted to give a sample of what ours might look like, where we kind of have a manager. For us, we're blessed, we have manager and coordinators. So ours is kind of a more tiered structure than this. But you really want that rolling up through a dyad structure, or where you have a clinical and administrative lead over a program. That way you can make sure that you're getting the right clinical care, but you have someone really focused on ensuring the technology is meeting the need as expected and desired by that clinical team as well. And with that, you want to have your trainers, your specialists, your facilitators, your presenters, all trained up under that same organization so that we're working together as one team and we're moving in unity towards a common goal together. And finally, I'll say that as we start transitioning over to the IT aspects of it, we really want to think about how do we evaluate technology. But before I go into this slide a little bit, let me pause and see, Are there any questions about what I've stated so far? Any comments? All right, well, I will take silence as a no, and we'll continue to move on with the technology piece. So really, as you evaluate the technology, what we just walked through was start with the strategy, develop the strategy. What are your goals? What are the services that I need? How am I going to reach these patients? What are the endpoints? Is it directly to their homes? Again, what are the settings? And then you'll figure out your modalities. And I say that when you get started, you probably want to conquer the world, but is it realistic to set yourself up for success if you want to deploy all the services at the same time? And I'd really advise, unless you have a large team, that you start and prioritize those programs. So maybe the initial, particularly during COVID, a lot of organizations started with the direct consumer only modality, where we're just engaging the patients and delivering a virtual visit from their home. And their vision is to slowly roll that into traditional telemedicine, clinic to clinic, and further go into hospital-based telemedicine, where we're thinking of telestrokes, telepsych, et cetera. And so build that strategy and the long-term plan in your mind. That way you're not setting yourself up with overwhelming yourself with technology. The biggest thing is you want to make sure everyone has a good initial experience. We know that stigma is huge, and we know that patients and providers will be discouraged if they don't have a good experience, first experience in particular with the technology. So you really want to start smaller so you can control that, refine it, learn from that initially, and then continue to grow. You also want to make sure you're capturing the right data points to ensure that the value proposition you have, you're able to achieve. And that's why I say start small with pilots. We really like, for our programs, we like to start with a smaller panel of providers and patients for a new service. We like to get feedback on what's working, what's not working, what we should improve, and then improve that significantly in our first quarter, so that when we're ready to then scale it and fully launch it, so to speak, we have worked out some of the kinks, and we really feel like it's an efficient program that we can really make accessible for more patients. Again, aligning your technology needs and your services with your enterprise goals is huge. One thing that's often overlooked is, especially for large enterprises, how does this telehealth aspect integrate with other video communication services I have? We know now that virtual meetings are so common and everyone's doing it. Do we need to have a single platform that does our internal stakeholder meetings as well as our virtual visits? Do we need multiple different ones? Do we need conference rooms integrated into that? And so those are just some of the things you should think about, is if we can eliminate duplications of services by finding one partner that can help us with all these video communication needs, it'll likely induce more engagement from your staff and from your providers to use it and be more familiar with that technology, so they can be empowered to have a better experience. And finally, you want to get to a place where you have a standard process for evaluating technology. That way it's equitable and you're really finding the right fit for you. And that right fit is not always the right fit for everybody. And so as we transition to the next slide, I'll be passing this over to Mike to really get into the specifics from a technical side. But really, this says working with vendors and considerations for contracting. But again, I'll stress that I look for partners. And I say that because a vendor is just somebody that delivers a service. A partner is someone that's invested in the outcomes that you want. And I think I always look for a vendor partner that is tied to the same mission, the goals, and the strategy that we have. And they are a key stakeholder in helping us achieve that mission. So without further ado, I'll pass it over to Mike to go ahead and walk through some of what we do on the technical side.
So, and I totally agree with that. Vendors are some of our biggest partners, and without them, we wouldn't be able to stand up the programs the way that we do. So when initially starting those conversations, you want to get multiple bids and you want to build a relationship with multiple vendors. And the thing to keep in mind is when building these relationships, you want to make sure that you're open about what you're trying to accomplish, as well as what is expected from the relationship, such as who does what and where. And also doing your due diligence research and negotiating. And remember that everything is negotiable, from the work performed to the cost of service. And then find the right partner. And the right partner might not be who is recommended or what a Google search states your partner should be, but the right partner is who can best adapt and grow with your program. And going into contact considerations, we like to think of the first line of support model. Is this something that you are going to be supporting, or is this something that your partner or vendor is going to be supporting? And if so, what are the SLAs? What is the response time? Just things to kind of keep in mind, as well as the data provided and the accountability. And remember too, accountability is held on your side as well. And you need to make sure that you are getting what you need from them and keep them accountable to those SLAs, as well as the terms, flexibility, and those shared KPIs discussed within the contract. And then the cost of evaluation and life cycle. So the things that people don't tend to realize going into these contracts is that usually during initial implementation, you talk about the cost of licensing and what it is for the first year, right? But normally that's a reoccurring cost. And we don't think about the life cycle of the equipment as well. So in the IT space, in most cases, the life cycle for equipment is roughly 5 years or so. And after that 5-year space, you have to get new equipment. And then going on to technology, we like to think of both the setup and the application. And so what I mean is where are we going to set our equipment up? What is the right space? For us, it's best to be used in an enclosed space or a private space. And so what makes a private space? You wouldn't want to consult with a patient in an open area, right, about private information. And also think, is the defined space HIPAA compliant? So think of placing the equipment in a space that you typically would for an in-person visit. By following that rule of thumb, you're generally pretty good. In regards to audio quality, and specifically this point that we put here is, do you need headphones to listen to a stethoscope? Years ago, we were working with our cardiology program here at Renown, and they continued to complain about not being able to hear a heartbeat like they would during an in-person visit. So we worked through with them through about 7 different iterations of headphones and finally found the right pair for them. Now, it took time, but we were able to discover the right equipment that best met their needs. But not only that, we were able to build those relationships, not just with cardiology, but with all other facets or faucets of the telehealth space. So it allowed us to really kind of like come together, and it was a great experience in the end. But also in regards to those headphones, is the patient hard of hearing? Would the patient like additional privacy? So it's always good to keep an extra set around regardless of the space that it's being used for. As well as the microphone, it's kind of self-explanatory. You know, we think in this meeting that we're having right now, right? Like I'm speaking directly at the microphone, but sometimes we get a little too close or we get a little too far. And it's just things to kind of think about where the placement of the device is, as well as feedback. So if I were to turn my volume up extremely loud and I left my mic unmuted and someone else was speaking, it would go through that microphone and just create a terrible amount of feedback, which would just result in a poor patient experience. So just kind of things to take into consideration. Another thing that we like to look at, especially during the initial setup, is the network. And we need that strong, reliable connection. We recommend minimum 2 megabit symmetrical for HD and minimum 1 meg symmetrical for 720p. And we think about right now, us being in the Reno area or in any big city, and it's very common for us to find 400 megs or a gigabit connection. But this may not be common for our rural partners. And just keep in mind that even at 2 meg, cell service may be the best they have. So it could be a big ask for them. But also during the initial configuration of setting up the network between sites is the firewall. And it's not just an initial configuration, but it's also after initial implementation. So changes must be taken into consideration. And what I mean by that is if there's not a constant line of communication between IT at both sites, if you were to make a change and you go to do a telehealth visit, it may not work because of the firewall rules have totally changed due to perhaps a security vulnerability that they found. And in doing so, they close off additional ports just to be extra safe. And now your visits don't work. So keeping that line of communication open between sites is the key really to success. And then moving on to our hardware and software codecs. So a hardware-based codec is a device that was initially designed years ago for video conferencing and to handle video conferencing because PCs at the time were not reliable or fast enough to keep up with video conferencing. So they're kind of being phased out, but they're still very reliable. So a lot of people continue to use them. But with the hardware-based codecs, they're reliable, low maintenance, but they do come at a high cost. And what do I mean by high cost? Well, it's monetary because they can cost upwards of $3,000 to $5,000 per device. But it is also during the initial configuration. They do take a lot to go through and to get up and running, but once they do, they're very reliable. But there's also an annual reoccurring cost for most of these devices for updates and so forth. And then when we think of software-based codecs, it's more of a PC. So basically what we're using now in this application, which is Zoom, right? They're low cost of entry and they are platform agnostic. So I can use Zoom, I can use Teams, I can use anything I want basically in the video conferencing space on my PC, but it does have many points of failure. And what I mean by the many points of failure is there could be updates or potential configuration changes or group policy or security updates. And also relying on end users to be a bit more hands-on. So any of those pieces could be a point of failure, which would rely on IT coming back and touching the device in the future. So just things to keep in mind.
I could just jump in there really quickly too, for those of you who are maybe not as tech savvy and that you're just getting familiar with this hardware versus software codec. One analogy I like to use to explain it is think of a hardware codec as an old school phone. Plugs into the wall into a phone jack, and that's it. It's reliable. You can always call it. We still use them in the hospital for emergencies and for backup, but you can't do as much with it. It's not as flexible and dynamic. And think of a software codec as a smartphone. It's easier to use. You can install updates. You can be more flexible. You can be more dynamic with it. But at the same time, if you're not keeping your phone up to date with the updates and the technology and the applications, then you're going to have more points of failure. And so just think of it that way. To me, that's a good analogy to help us understand what's a hardware-based codec versus a software-based codec and how that can be useful. Sorry, Mike. And I don't know if we should pause. Are there any questions from the audience that, about these last two slides that Mike just went through? All right, why don't you go ahead and continue on, Mike? Sorry for interjecting there.
No, you're totally fine. And that analogy is fantastic. And I know we had talked about it the other day, and I actually meant to state that too. It's very good. So, and so bringing us on to security, we have to think of HIPAA compliance, right? Like, and so what does this mean for your organization, and how will you protect confidentiality of the visit? So by using that enclosed space that I discussed earlier, as well as encrypting your data, you usually fall into this and you're pretty good. But we also recommend that video and images are not stored by default or sent via instant messaging. So something like Teams or the like. We strongly recommend not saving any data locally in regards to patient data. And it's always best to follow best practice set by the IT department of your organization. But because of COVID and the HIPAA flexibility during this time, we also like to remind our providers that convenience doesn't necessarily always mean that it's the right thing to do. And because of the lax laws, we just like to bring that up over the past year with COVID. But moving on to end-to-end encryption, this is kind of the big key, and this is what keeps your data safe as you're going from one site to another. And this is really kind of where the firewall stuff plays into as well. But from a high level, encryption is the protection of data through a public space, which requires a secret key to encrypt and decrypt. Currently, at this point in time, at least from an article that I had read this last year, AES 256 has not been broken, and is what our federal government uses to protect its data. So one thing to keep in mind, I give you a little bit of ease in regards to the security space. And then we also like to use unique meeting IDs. So when joining this meeting, if you joined it through an email, you'd see the zoom.us, and then there's a set of numbers at the end of that. That set of numbers is a unique meeting ID. So we're not all joining the same meeting over and over and over. Every time you schedule something, it creates something unique. Some programs, they do like to use VMRs, which is a virtual meeting room. So as an example, for a telestroke program, in the past, what we used to do is we would have both sites dial into a number to meet at a single time. But we found that that would lead to failure in many instances due to miscommunication. So one site would dial in, they'd wait there for about 3 minutes, and then they would leave because no one had joined. And within 30 seconds of the provider leaving, the patient side would join in, and then they would go back and forth. So using unique meeting IDs is great, but in that specific space, we do direct dial as well. But in regards to doing VMRs, you may think about using a PIN or a password to protect it. So that way people don't jump into that meeting by accident and jump into a provider and patient encounter. And you may want to take into consideration using a waiting room for extra security. So as an example, if a patient were to join a virtual visit and a provider was just jumping in after the patient, and let's say he had some information up in the background and he didn't want anyone else to see that, if there wasn't a waiting room, he would jump right into it and the patient would see it, right? So by using that waiting room, the provider can decide when they are ready and then admit the patient at that time. And then we go into platform management. And here is really kind of key to your security, as well as the encryption and firewall rules as well. But you want to make sure that you keep your platform up to date at all times. And also being very wary of robo-dialers. And so in regards to the robo-dialers, most public-facing IT systems are constantly getting hit with attacks. If there are firewall changes or firewall rules were incorrectly set during the implementation process, your systems may get hit with constant spam and be unable to perform telehealth visits. So it's just one thing to keep in mind. It doesn't happen very often nowadays because we're generally pretty good about it. But if you're having any sort of issue in that regards, you may want to reach out to your IT. As well as maintaining systems. So schedule minimally invasive planned downtimes. And so here, find a space where volume is usually low to perform your patching and updates. And you want to keep your system as up to date and secure as possible. But a general rule of thumb, and what we recommend, is not being more than 2 patches or firmware updates behind. And moving into considerations, is you want to have a strong support plan at both sites. And that means having the technical staff available to support connectivity and hardware issues. So for us, it's big. This is probably one of the areas where I would say either will lead to the most success or the biggest amount of failures. And that's the communication between IT. Because again, falling back into the firewall discussion earlier, where if a site makes a change and you're unaware of it, then it breaks. But if you do the same thing on your side, you may very well cause that same issue. So having that constant line of communication is huge. And also doing any tests anytime that any of these changes are made. But you also may want to take into consideration the time of operation of your program. So is it 24/7? How will your technical staff support it? And how will it meet the business hours of operation? So as an example for us, our telestroke process currently, if they are having an issue, they call a number, and that number or extension, if you will, hits all of my team's phones, including myself. If we don't answer, it goes to a voicemail. That voicemail then goes to our email. All of us have that email on our phone, and we get that notification as soon as that voicemail comes in, so we can get to it as quickly as possible. After 10 o'clock at night, it goes to an on-call phone, which is rotated between our group on a 2-week basis. But that's how we keep up with it, and we found that's what works best for us. And the maintenance and support plan for the hardware is highly recommended. Many vendors offer this service, and you may work with one that already does. For us, we have found it highly beneficial during the patching process to make sure that we have someone from our vendor on with us in the event that something breaks, because that gives us instant access to an engineer, and we can solve the problem as quickly as possible to create the least amount of downtime in the event that something does break. And we also like to do quality assurance testing. And for us, this allows us to find problems before visits and leads to a higher success. So as an example, we have a scheduling team, and every morning our scheduling team reaches out to the sites that are having visits for the day, and they do a QA with them. During this QA process, they'll test, make sure that they can see and hear each other, make sure video looks good, make sure they can share their screens, make sure the peripherals attached to the cart are working and functioning properly. And if they have any issues, they reach out to us, and they usually reach out to us via Teams. And by doing QA in the morning and having a set time, we know that this is the time where we need to be at our desks as IT and make sure that we're readily available. So when something breaks, our response time to the QA process is generally around 5 to 15 minutes, just to make sure that there are no missed visits throughout the day. But you also want to make sure that you QA with sites routinely, regardless of volume. And so again, to use Telestroke as an example, you may have an external partner that only utilizes those services on average once every 3 months. But it is key for that equipment to work during those visits. So we recommend doing a QA with them once a week, just to make sure that that equipment is good and functioning properly. And then you may want to think of EMR integration. How are you going to bill for this? And how will providers like to use or utilize the space? Are they going to go through the EMR to utilize the telehealth program? And then the provider and presenter engagement for reporting issues and troubleshooting. And for us, really, like, this is one of the biggest keys to success, is getting those engagement levels up and building the relationships between the providers and the presenters with IT. For us, it's led to much higher engagement, and anytime we have issues, we're generally notified about it almost instantly. We'll get a call from them, and because we have built those relationships with them, we know the equipment. Generally, we know what device serial number, as an example, they're using, so we can get right into it and solve the problem. Because the last thing that we want to do is to have a patient come in to use this equipment or utilize a telehealth visit and not be able to complete it and have it be a failure and then have to reschedule.
And just to add to that, I love what Mike said, but there's an additional piece with that as well. When you're getting that engagement and that feedback in real time, you can do what Mike said and troubleshoot in the moment. But furthermore, you're aware of what's happening, and you can start looking for trends, patterns to address root cause. And that root cause might be technology, it might be training, it may be a single site, in isolation to a certain area. That's the only area that's having that consistent problem. And so it's about using that data and that feedback to give them the right care and the right service in the moment, but also to improve your program and continue to refine what you're doing to make it a better experience in the long term.
Absolutely. And moving on to this next slide, we just wanted to throw a slide in here just as a recommended and a minimally viable recommendation for the platform program itself, like we had discussed earlier. But I'll go ahead here and pause for any questions.
Any questions at this time? We've got about 12 minutes left, and I think we've just got a little bit left in the presentation, but feel free to unmute yourselves or write in through the chat box.
So with that, I'll hand it back over to Mitchell.
All right, well, we've got some content here laid out just in case we didn't have as much active dialogue and discussion. But again, we want to make this as valuable as we can for you. So please ask questions here. I see one coming in the chat that says, how does Zoom compare to your recommendations? Mike, do you want to take a stab at that one?
So, I mean, it depends on what you're trying to do. So from our experience, Zoom has been very reliable. It's been a great platform for the virtual visit space. I've really enjoyed it. The integration was extremely straightforward and easy. It takes time, obviously, but I feel as a whole, Zoom has been pretty good. But again, it depends on what you're trying to accomplish and how you're utilizing that service. And I'd say that probably with every video platform. And I know that's kind of like a vague answer, but it really falls back into what you're trying to do. Of course, my pleasure.
Thank you for the question, Deborah. So here, we just wanted to get to sustainability. You know, we talked about the strategy, we talked about creating the plan, defining what those metrics are, evaluating the technology. And I think the biggest thing is you want to make sure that technology doesn't just meet the need today, but it sets you up for long-term growth and the ability to scale as well as sustain. And so with that, that's why we really focus on the partnerships to get the right service, collecting that data. But furthermore, continue to evaluate studies and create your own white papers. If you're doing something that's innovative and new for yourself, your organization, let's create a story about it so you can evaluate and hold yourself accountable for evaluating the impact of the program, but then furthermore, so you can use it for marketing, negotiations, discussion with patients to really engage them a little bit more. Always look for opportunities from grant funding. We know during COVID in particular, there was a lot of grant funds out there from the FCC across the board. USDA has an annual DLT grant, a distance learning and telemedicine grant. So I encourage anyone to look at that to try to apply for funding. And donors. I mean, that's another part of why we like to collect that data and tell that story is telemedicine is a hot topic, and getting patients the right care at the right time is one way that we can really help influence and hopefully reduce the healthcare deficit while improving the quality of care in our country. When we think about getting patients the right care at the right time, what we're really trying to impact is the quality of life for those patients. And so let's look at other opportunities with donors and funding that are also invested in that mission. And I think you'll find that there are many that are interested in pursuing that goal. So again, you'll want to look at the ability to scale your processes and grow your different service lines so that you may start with just an urgent care virtual service, but over time, can we deploy a primary care virtual service? Can we do specialties? Whatever that is for you, look at it and think about how do we plan for that future to make sure we can be sustainable as we need to move forward. And that's going back to that point about being agile and flexible. We want to make sure you can be dynamic because, again, the vendor that's the best choice today may not be the best choice in 2 years when that contract expires. And so you want to make sure that you're flexible and you're not dependent on that vendor to make that meaningful change and provide that right care. We don't want disruption when you make that change. We want improvement. And that's what I think is the best thing, that if we think about that from the patient perspective, we don't want to be disrupted. We don't want to have to change and relearn everything we do. We want to see the tool upgraded or updated so that we can continue to use it with more tools and better features. And then again, with that, integrate, align with your long-term goals so you have those ROI opportunities, metrics. I use remote monitoring here as an example, but really thinking if your goal is to shift to home-based care and a consumerization of healthcare, how can remote monitoring play a factor in that? How can we continue to monitor those patients to keep them healthier instead of wait until they're sick before they engage with us? So as we move forward, what we wanted to just give is kind of a sample of what a strategic building process would look like. So for us, we always think about starting again with that oversight committee, your key stakeholders, assign who they are, get that committee together, create a value proposition and goal for that committee, maybe put together a mission statement from that group so that as you roll this down from an enterprise level to a department level, we're making sure that we're achieving that mission and that common goal and really defining those pillars for success. Is it quality care? Is it timely care? Is it pop health? Is it patient first, patient centric? Is it provider centric? Are we trying to make it easier for providers to use? Is it both? And again, for us, it's about, I always recommend, go back to that quadruple aim. If the technology is going to be successful, it's going to be easy for providers, easy for patients, while controlling costs and improving quality. And that's what we really want to do with the technology. That's how we can empower ourselves to augment our traditional medicine system to move forward into the future with the tools that exist today. And we'll continue to develop, and hopefully there'll be even more tools in the future. So with that, I say, create these goals that can cascade down from the top, from a programmatic level to a director level, a manager level, all the way down, so that every person along the continuum of care, along the process, feels like they have a role in achieving that mission. I think that's extremely important because we tend to see that employees and providers, care team members perform the best when they feel like they're dedicated and they have an impact on achieving that mission. And if those goals aren't clear on how they're going to improve the care for the patient, you're going to likely see people that are doing a good job when they could be doing a great job. And that's what we want to really encourage is these patients deserve the best care. So let's continue to strive for that as we move forward. For us at Renown, just as a sample, we kind of take a lot of these same pillars that I have on this screen, but on the next slide, you'll see our Renown version of it is very, very similar. But we look at that quadruple aim, a pop health first. We want to deliver that right care, right time. I'm in our mission statement there at the top. But really, when you look at the graphic on the right, that's what we really try to do is reduce our variation by standardization. We want to continue to optimize our infrastructure with that continuous process improvement. We want to develop our network and continue to grow in a way that's scalable and sustainable so that we're only innovating in investments on things that we know are aligned with what we're trying to achieve in the future, in the near and the far. And ultimately, that goal is then to exceed the expectations for access and affordability for care while never sacrificing quality along the way. And taking this one step further, let's say if you're just focused on a specific single program like a telestroke program, well, for ours, we wanted to make sure we can deliver 24/7 care, real time, high reliability. So we wanted to get that assessment done in all of the communities that are transferring facilities to our stroke center so that we can determine, A, what's the need for this transfer? B, is the patient eligible for treatment for TPA? We know that window is short. We know it needs to be started soon. And so is it possible to start that prior to transport? Can we do that during transport? Or is it something that doesn't even qualify and we actually don't need to see the patient or transfer the patient here because we can assist you virtually with our providers and you have the skill set to deliver that remotely in your hospital setting? So that was kind of the value proposition that we came to. And then we looked at key metrics. It was that door to needle time and that treatment time. So how soon can we get that patient seen? How quickly can we administer that TPA if they're eligible? That's the window that we were looking at, knowing that every minute, millions of brain neurons are lost during a stroke. And so we want to combat that as soon as possible because we know patients that get treated within 24 hours are those that are going to have the best success for full recovery. And the sooner, the better for a stroke. And so that's kind of what we built out as our quality metrics, our value proposition, and then some of the key things that we really wanted to align with were our ACO and CMS quality performance measures, as well as our standard stroke association metrics that we track. So again, just a sample of how we've looked at and used that logic to deploy some of our programs. That's everything we have for the content today. And so we would love to ask if anyone has any other questions. We would love to answer them if we can.
Yeah, Neil, go ahead.
Yeah, thank you. Thank you all for the presentation. One of the questions I had is there was some concern in previous to the popularity of telemedicine and telehealth and those conversations that there wasn't a lack, I think there was a lack of reimbursement. And so then during the pandemic, there was an allowance for a temporary allowance for reimbursement. as you know, kind of, it sounds like most organizations, and especially yours, is moving forward with this and investing heavily for the future. Is your expectation that those reimbursements will be permanent and in place, or are you guys still working on getting that to confirm?
Yeah, so I'll say that everything I've seen in literature is that we're moving towards making a lot of those expansions permanent for those additional codes. And we're really pushing forward to make virtual visits, which is that direct-to-consumer model, also reimbursed at the rate of an office visit if it qualifies. I think that's the key, is it has to qualify from a clinical documentation and service delivery perspective to make sure that it's going to meet that need. I do foresee that we'll move down that route. Well, those will be reimbursed in the direct-to-consumer model. A lot of states are already taking that initiative. And I know that our state, for Nevada, for our Medicaid programs, we're moving in that direction of reimbursing at parity and proposing at least to move that direction for those virtual services as well. So I do think there's a shift in that. And a lot of what we're seeing is contracting with commercial payers in a capitated or managed care model where you may not get paid as much for those services, but the value of delivering those virtual services will allow you to get paid on the back end of it because you're controlling the cost of that care. I know there's other experts on the line that may also have some thoughts here. Does anyone else want to chime in on their perspectives of reimbursement in the future? All right. Well, hopefully that perspective is enough for you, Neil. Sorry.
No apologies necessary. Thank you. I appreciate that. And one other question, if I may, I understand there was a big celebration around the infrastructure bill that the federal government, just passed, and it involved this kind of rural investment into things. Is that something that is going to be directly for this kind of initiative, or is it more just kind of cellular service for people in the rural areas?
So I'll say that I think I have to research that a little bit more. My general understanding, though, is that it will impact our services just from the perspective of creating more access. 4G across the country, broadband across more places will make it more accessible. I'm not sure if there was a call out specifically for telemedicine technology, but I do think that that expansion of coverage from a cellular and broadband perspective will be extremely helpful for a lot of those communities and allow us to use this more flexibly in all locations.
Yeah, great. Thank you very much.
Absolutely. Great questions. Thank you.
We are at time, but I want to make sure everybody has a chance to get their questions answered. So any other questions from the group, feel free to unmute yourselves or write in through the chat box, please.
I have a question. I was on clinicals for the last year at different sites throughout Nevada, and a lot of the places I've been at have used Zoom for their platform for telemedicine, but I was wondering what other platforms there are available that you guys have experienced that are meeting your recommendations and are effective for telemedicine, especially in rural areas. If anyone can speak to that.
So that's a very broad question. It's a really good one, but there are many different platforms that are HIPAA compliant and can meet that need. And I think that's where Mike really wanted to stress, go out there and look for bids and make sure it's the HIPAA compliant version of it. So for example, Microsoft Teams has a HIPAA compliant version, Zoom has a HIPAA compliant version. Almost every video vendor that you'll see now likely has or is working on a HIPAA compliant version. And a lot of these different platforms include a video capacity behind them as well. So maybe we can take that offline if you want to look for specific recommendations and how we evaluated each. I don't want to promote one or the other here, but I'll say that we're intimately familiar with a few of those that I described, Polycom, Teladoc, as well as a few others, but those are ones that we actively use today.
Thank you.